who has had 2 previous cesarean sections and 1 normal delivery. There is a history of 1 IUD, and second child was CP, expired after 1.5 years. And third child had neonatal seizures and had early neonatal death, was delivered by cesarean section. Now she is at 8 weeks of gestation and concerned about normal healthy child in current pregnancy. What will be important history points you will ask? What will be your plan in current pregnancy, and how will you counsel her regarding chances of a normal baby in this pregnancy? 3 सवाल हैं. History में क्या points आप पूछेंगे? I would suggest that all those who are participating in this activity, please take a snap of this slide, and you can later on dilate upon that, and you can think about the and read about the material, relevant material, and answer these questions. Inevitably, the answers to these questions will also raise certain questions in your mind, and also points which you may need to know about more. So that's what you that's how you enlarge the scope of your knowledge, because the management of this patient is not restricted to only these 3 questions, although broadly these 3 questions do address her concerns and the status of her present pregnancy and the course that it ought to take under medical guidance.
Important history points will be the detailed history regarding her previous pregnancies, like exposure of drugs and toxins, maternal thyroid disorders, gestational diabetes, prenatal ultrasounds.
नहीं, प्रीनेटल अल्ट्रासाउंड क्या बताएगा आपको? 3 बच्चों का उसका मसला हो चुका है. You see, it is highly unlikely that there would be a recurring factor in the management of her pregnancy. आप डायबिटीज को रूल आउट कर लो, but does diabetes lead to CP and neurological problems like this?
Consanguineous marriage, family history of anomalous baby, and about blood group of the patient.
Blood group का क्या ताल्लुक है इससे? ये देखिए, you have to be specific. We are not discussing some hydrops की बात नहीं कर रहे हैं हम. ये है specific problem है, which is a neurological problem. वो देखिए आपने family history की बात की है, that is important. और चलें, because whenever you talk about genetics or you think that there is an associated factor, genetic associated factor, then you draw what is known as a family tree on the mother side as well as on the father's side.
So history of epilepsy in mother, is she taking any antifolate, anti-epileptic drugs? Is there any history of epilepsy in the father?
चलिए, ऑल राइट. इन्होंने भी कहा था एक हिस्ट्री में आप ड्रग की हिस्ट्री लेंगे, आप एपिलेप्सी की हिस्ट्री ले लें, आप मदर की साइड की और फादर की साइड की, दोनों के साइड में न्यूरोलॉजिकल प्रॉब्लम्स की हिस्ट्री आप लीजिएगा. ठीक है जी. These are the important points in history, and when you are taking that history and you are drawing that family tree, you are also identifying any individuals in both the families, mothers and the fathers, who may have been affected by neurological problems. So that is the historical points. Now, what is your plan in current pregnancy? नहीं, इस तरह से ना करो. बेसलाइन इन्वेस्टिगेशन, हमारे पास टाइम नहीं है. दिस हैज टू बी फोकस्ड कि इस मसले के लिए आपने क्या करना है. हम यहाँ हीमोग्लोबिन ब्लड ग्रुप करने नहीं आए हुए. आपने पढ़ा इसको? क्या पढ़ा था आपने? अगर पढ़े बगैर आए हो तो फिर रहने दो, फिर हम वैसी बात कर लेते हैं, and then we will get on to the other thing.
So the patient should
हाँ
have
जी,
an early booking. Folic acid supplements and aspirin should be given to the patient, and she should be screened for all the investigations. Her HbA1c should be done because the first child is IUD. So all the investigations regarding the diabetes
ये
and
all एक मिनट ठहरिए जरा। आप ये अल्फाज जो होते हैं ना, ऑल इन्वेस्टिगेशंस और एनी, इनका कम से कम इस्तेमाल कीजिएगा। ये मैं कम से कम वैसे तो मैं कहूँगा कि बिल्कुल ना इस्तेमाल करें, कम से कम मैं इसलिए कहता हूँ कि मैं खुद कभी कभार इस्तेमाल कर जाता हूँ। So therefore, all the investigations doesn't take you anywhere. It doesn't really mean anything. You have to be specific, like you said, that you will do hemoglobin A1C. All right, that's relevant. History में दूसरे points हो गए। आप
TSH.
डायबिटीज मेलाइटिस को रूल आउट करना चाहते हैं, वो कर दिया आपने। उसके बाद आप क्या करना चाहते हैं?
Sir, TSH, because if
All right,
the patient is
thyroid.
hypothyroid, yeah.
All right, that thyroid, is it known to cause neurological problems like these?
Sir,
Hypo or hyper?
hypothyroidism can lead to cretinism, but it does not go for neonatal seizures.
हाँ, वो इसमें नहीं जाता ना, तो इसलिए आप जरा ये करें, अगले सेशन में हम 5 मिनट लगाएंगे और इसकी इन्वेस्टिगेशन सारी जो हैं वो लेके आएंगे। आई हैवंट हैड द टाइम टू डू दैट, लेकिन इसमें मैं तो प्लान ये करूंगा, बिकॉज my attention would be directed towards CP. Now, CP till about 20 years ago was considered to be a hypoxic event, or a result of a hypoxic event, intrapartum hypoxic event particularly. But later on, then antenatal hypoxia or chronic hypoxia, that also came in. And now we know that there are mutations of certain genes which result in this. And those genes are transmitted from the parents. And therefore, knowing those genes, मैंने आज सुबह 2 मिनट में ही वो निकाला कुछ थोड़ा सा आने से पहले। क्या फजूल है ये।
आप भी बता दें, मैं भी कुछ बता दूं।
मैं बस बता रहा हूँ, ये 2 genes हैं, FBXO31 and RHOB. When mutated, are each alone sufficient to cause cerebral palsy. Many of the additional genes carrying mutations were only present in the child with cerebral palsy, meaning they arose randomly. So there is possibility of random, but that would be only relevant in case where there is one child like that. But if there is repeated incidence of this, then one has to go for that mutation of genes in the children, in the parents. And tests like recombine may help in this. So regarding counseling, it has to be guarded. You can't really say that your child is going to be CP again or would have a neurological problem. You can say that it would have been much better if we had investigated the mother as well as the father before the pregnancy started. But what now we can do is that we can request this genetic assessment, and depending upon the outcome of that, one would then assess the chances of this baby being affected by, and I am not sure whether chorion villus sampling would help in that or not, but that also can be a possibility to identify the presence of those genes in this particular conceptus. And depending upon that, continuation or termination of pregnancy will be decided. So that would be my counseling to the patient. जी
मैं बेसिकली ये कहना चाह रही थी कि जब आपके पास इस किस्म की एक चीज आती है जो कि डिफिकल्ट है और आपको इमीडिएटली इसकी सेंस नहीं है, यहाँ तो आप लोग पहले से इन्फॉर्म थे, तो यू कुड हैव स्टडीड द टॉपिक, बट always summarize the case when you are presented with this, ताकि एग्जामिनर को पता चले कि आपने उसमें से क्या चीज पिक की है. So this is a young female who has got previous 3 pregnancies. The first was IUD, the second was CP child who died at 1.5 years of age, and third was neonatal seizures and early neonatal death, and now the patient is 8 weeks pregnant. So the most important thing I think in this is to try to find out a cause for what happened in her previous pregnancies, which will guide you through this pregnancy as well. So when we're trying to look for a cause, when you look at it, generally, it seems that the cause for the pregnancy losses in each pregnancy was different. It does not seem that it is the same cause every time. But if you look at it carefully, IUD, CP, and neonatal seizure all can happen by hypoxia. So you have to look for a cause which is causing hypoxia to the baby at some point in time. And generally, जैसे डॉक्टर फरूक ने देखा, मुझे भी ऐसे बैठे बैठे causes नहीं पता. So I just scanned through it and it said कि 3 तरह के causes हो सकते हैं. Structural हो सकते हैं, metabolic हो सकते हैं और genetic हो सकते हैं. जो स्ट्रक्चरल है उनमें कोई हमारे पास एविडेंस नहीं है. स्ट्रक्चरल द पेशेंट हैड अ cesarean section, you have to take history of any structural abnormalities, but what kind of structural abnormalities would produce these three things? तो मैं तो स्ट्रक्चर को एक किस्म का साइड पे कर रही हूँ. फिर बच जाते हैं आपके मेटाबॉलिक और जेनेटिक. मेटाबॉलिक कॉजेज में जनरली द बेबी डज नॉट डाई इन यूट्रो. बेबी की डेथ बाद में होती है. So though metabolic cause could be there, but the likelihood seems to be low. And the third is genetic, and the fourth is infections and pregnancy. But what infection will be happening again and again? So then it remains for you to think about genetic causes. That there is some, so you must talk about a genetic counselor. You must talk about a fetal medicine specialist from whom you can take help. And then you try to, if the patient can afford it, after counseling, a genetic assessment should be done of the parents. जिसे सर ने 2 genes बताई, उसके point of view से genetic assessment इस वक्त हो सकती है because the patient is only 8 weeks pregnant. It generally takes 3 to 4 weeks for the results to come back. So if the parents' reports come back in 4 weeks' time, then according to that, if you find some genetic cause, you can do sampling either through CBS or by amniocentesis and send the sample for testing of the baby. And based on those reports, you will make a decision whether the pregnancy should be continued or not. This is my take on this everything. उसके मुताबिक आप पॉइंट्स इन हिस्ट्री निकाल लें, उसके मुताबिक आप इन्वेस्टिगेशन और प्लान और काउंसलिंग सब कुछ उसके मुताबिक बनेगा. जब भी आपको कोई केस मिलता है एग्जामिनेशन के अंदर, उसका बैकग्राउंड, उसकी प्रीएम्प्ट करना, उसका पहले पूरा एक केस बनाना जरूरी है. सीधा आप जवाब नहीं दे सकते. इस क्वेश्चन को आप 100 दफा पढ़ लो. I don't think any one of you will be able to find any significant points in the history. अब जाहिर है इसमें डायबिटीज भी आप स्क्रीन करेंगे, आप एनोमली स्कैन भी करेंगे, लेकिन सवाल का मतलब समझ आया कि नहीं आया? सवाल का मतलब कोई नहीं समझ में आया. जितने लोगों ने आंसर दिया है, मेरी नजर में सवाल किसी को समझ में नहीं आया. सवाल ये है कि न्यूनेटल सीरियल है, सीपी है और आईयूडी है. ये क्यों हो रहा है? और जिसको ये केस पहले से पता था, उसकी तैयारी में you just had to go on the Google and look for cause for neonatal seizures and you would have reached it, or you should have looked for cause for CP. ये जब प्रिपेयर करते हो किसी केस के लिए तो उसका होमवर्क प्रॉपर्ली करना बड़ा जरूरी है, वरना वाइवा हो ही नहीं सकता. सो कॉन्सेप्ट बनाओ अपने टॉपिक का. जब आपका उसका कॉन्सेप्ट अपना क्लियर हो जाएगा, तभी आप एग्जामिनर को समझा सकोगे. जब अपना ही क्लियर नहीं है तो फिर आप एग्जामिनर को क्या बताओगे? मैं तो इसको ऐसे देख.
ठीक है जी, चलो नेक्स्ट केस पे चलें. अब ये मैं इसको नेक्स्ट केस पे चला रहा हूँ, ये चल ही नहीं रहा. हाँ जी, ये वैसे केस नंबर 2. अब ये इसको जाके वहां से बंद करो, उस पे चला हुआ.
मुझे एक सवाल करना है उस केस से रिलेटेड. मैंने ब्लड ग्रुप का कहा, आपने कहा इसमें ब्लड ग्रुप की इंपॉर्टेंस नहीं है. उसमें भी तो आईयूडी होता है और न्यूनेटल सीजर्स भी हो सकते हैं, कर्निकटेरिस अगर डेवलप कर लिया आफ्टर डिलीवरी.
लेकिन कर्निकटेरिस जो होता है वो बाद में बच्चे के पैदाइश के बाद होता है. देयर इज हिस्ट्री ऑफ नियोनेटल जॉन्डिस. देयर कैन बी हाइड्रॉप्स इफ देयर इज दैट RH isoimmunization is of that extent, then there would not be IUD in the first pregnancy. There has to be certain morphological features on the of the baby जो कि होगा repeated इस तरह से. And जो कर्निकटेरिस है वो बाद में later on develop होता है, वो CP उस तरह से नहीं है. और फिर सीजर्स की बात भी हो सकती है, लेकिन if it is so the intensity of effect of RH isoimmunization is of that extent, then the pregnancy is doomed quite early on.
थैंक यू डॉक्टर, और आपकी आवाज आ रही है. थैंक यू.
ठीक है, ओके. वो दूसरा दिया था. let me tell about this.
सर इसकी मैनेजमेंट में क्या है, अगर जेनेटिक कॉजेज है तो दोबारा भी हो सकता है या सीपी हो सकता
नहीं,
है
अगर
या
देखो जेनेटिक कॉजेज हैं तो फिर NIPT किसी ने लिखा था, आई डोंट रियली एग्री एट दिस पॉइंट इन टाइम. NIPT will not tell you that greater detail. Either it will be chorion villus sampling, CVS, or amniocentesis, because that will afford the, I am not sure about that though, because NIPT is only concerned with some fragments of DNA, whereas probably in this you need more than that for assessment of the genetic makeup. And depending upon the genetic makeup, then you will, it is just like thalassemia, for example. That's a very simple example. How is thalassemia transmitted? Thalassemia minor, or and so on and so forth. So that's the comparatively simpler form of understanding progression of disease in the children. So therefore you just go on to that और उसके मुताबिक आप देखिए. ये दूसरा केस है, इसको 10 मिनट में करेंगे. इसमें कुछ सवालात हैं जो उभरते हैं जो मैं आपको बताऊंगा. यंग वुमन,
इसको समराइज करने दें सना को, आप ना बताइए.
चलो
यही पढ़ दो जो सामने लिखा
बोलो.
है.
वो ये पढ़ दो ना, सामने तुम्हारे है. फिर
29-year-old female married for
एग्जाम की तरह बताओ ना, तुम तो ऐसे बोल रहे हो जैसे बिस्तर में हो. सही तरह बोलो. 29-year-old Tara 3+0 delivered by cesarean sections. चलो आगे.
with one male alive and well, two females IUDs and
two female नहीं, and number one, first pregnancy, second pregnancy, and third pregnancy.
Second was a female which was an IUD, and third male baby which alive and well. Last child born was in May 2020. Her menstrual cycle is regular with her LMP of 15th of October 2000.
She presented on 10th of March.
She presented on 10th of March with the complaint of heavy vaginal bleeding for 10 days. She had history of IV venifer infusion 1 day ago. In her investigations, her hemoglobin is 6.3 gram%, which was done on the 9th of March 2022. Her ultrasound was done the following day, which revealed a gestational age of 18.6 weeks. Placenta posterior, cervical length was 45 millimeters. There was fluid in vagina, subchorionic vein on the left wall, 65 into 67 millimeters.
Now, this is the patient who had a large hematoma. She was bleeding and she had bled to the extent that the hemoglobin had come down to 6.3 grams. And she came from outside the city. And this was the situation. Now, how are we going to counsel? Because there is a considerable amount of blood inside, and there is a large clot in the. If you look at this, on this picture, this is the clot in the uterus. Placenta is in the upper segment, in the mid-uterine upper segment. This is bladder, this is the clot. And after 10th of March, this patient came on 1st of April. Still, she was bleeding, and in the intervening 20 days, she had 3 units transfused, but still her hemoglobin was 7.4 grams, which meant that she had considerable amount of bleeding. On 1st of April, her fundal height was 24 weeks, and on ultrasound in the clinic, fetal movements were there, Liquor was adequate, and there was a mass or clot in the lower part of the uterus, which is shown here in this diagram. How are we going to proceed? Over the last 3 weeks, the patient has continued to bleed. There is presence of a large clot in the lower pole of the uterus. She has previous 3 cesarean sections, and now she is at about 21 weeks, 21 or 2 weeks, according to the scan which was done on 10th of March. So how are we going to counsel the patient? Counseling हर चीज में बड़ी important आ जाती है. 3-4 फिक्रों में वो counseling करने की जरूरत है, और बाकी मैनेजमेंट जो है वो कोई इतनी मुश्किल नहीं होती.
बोलो.
My management would include an initial resuscitation of the patient, maintaining IV line.
Resuscitation वो कोई collapse condition में आई हुई है, वो clinic में आई हुई है.
6.3 my case.
Resuscitation होती है जब collapsed patient को resuscitate कर रहे हो.
So if a patient's hemoglobin is 6.3, would you resuscitate her?
By resuscitation, I meant that, you know, I would,
No, resuscitation is resuscitation of a patient who is unresponsive.
You do resuscitation for a patient in shock. और आपको लगेगा शॉक में जा रही है. So अगर pulse और blood pressure उसका ठीक है 6.3 के साथ, so she would not need resuscitation.
but I would pass an IV line, maintain IV line. I would give her IV fluids and withdraw baseline investigations.
I would differ with you. If you give IV fluid, you would be further diluting hemoglobin. 7.4 तो hemoglobin है उसकी इस वक्त, वो चलती हुई आई है.
ये अभी थोड़ा सा change हुई, मुझे जो मुझे सर दिया था वो था
मैंने तो वो
6.3.
जो लिखा हुआ सामने उसकी बात कर रहा हूँ ना
ठीक है.
बच्चा.
Okay, so now I will start with a detailed inquiry, inquire about the detailed history of the patient from the attendant or the patient himself.
कौन सी हिस्ट्री क्या पूछना चाहते हो?
कि कितनी heavy bleeding हुई है in the last 10
ये
days.
पे देखो, बात सुनो. उसकी जरूरत है जो बता रहा है कि 20 दिनों में 3 यूनिट ब्लड ट्रांसफ्यूजन के हुए हैं और उसकी हीमोग्लोबिन 7.4 की वही है.
3 हफ्ते होते हैं, ठीक है ना? तो 3 हफ्ते में 3 ब्लड जाते हैं.
लेकिन फिर भी hemoglobin इतनी build up
हाँ,
नहीं
तो
हुई.
और क्या हिस्ट्री लेना चाहते हो?
नहीं हुई and she
Bleeding के
continues
साथ
to
कोई
bleed.
pain थी? Was there any pain associated?
उससे क्या
with
फर्क पड़ेगा?
eruption में तो pain होती है और वैसे painless है तो लेकिन
अंदर क्लॉट नजर आ रहा है, एब्रप्शन.
Eruption तो है ना?
तो फिर इसको तो
काउंसिल क्या करना है? सो पहली बात यह है, देखिए
इसको
इसमें जो कैंडिडेट ने जो बात की है, she had the opportunity of looking at it and formulating the questions कि क्या करना है. So whenever you ask question in the history, it should be relevant. ये नहीं है कि हर हिस्ट्री में और हर सिचुएशन में आप वही सवाल पूछेंगे कि I'll take a detailed history. भाई आपने डिटेल्ड हिस्ट्री क्या है? हम 10 मिनट की बात कर रहे हैं. It has to be extremely focused. कि क्या चीज कि I'll take the history of bleeding. Now this is all apparent. You don't have to ask her. If it says that 3 units were transfused and her hemoglobin still is 7.4 grams, that means that she has been bleeding continuously, and at least during these 3 weeks, she has lost about 3 pints of blood.
Yes, I would counsel her that this is a high-risk pregnancy in which there are risks associated to the mother and the fetus,
Good.
maternal risks of anemia. There is also a risk of prolonged hospitalization, further blood transfusions and complications associated with blood transfusion. Also, this increases her chances as she has had previous 3 cesarean sections, so she has an increased risk of operative delivery. Fetal risk.
Increased risk because of this bleeding? वो तो है ही.
We will go for an operative delivery in this case.
ठीक
Also,
है.
I would like to explain to her the risks to the fetus, which will include fetal hypoxia, growth restriction, and as she is at 20 plus 6 weeks, I would counsel her that this is not a viable pregnancy, and there is also risk of prematurity and intrauterine fetal demise. So therefore, in light of the ultrasound, the history, examination, investigations, and the ultrasound, I would arrange. I would for
You would
blood.
suggest.
And I would suggest that there should be at least 4 units of blood arranged, and I would involve a multidisciplinary team, which would involve a senior gynecologist, anesthesiologist, and a neonatologist. And
Neonatologist ने इस वक्त क्या करना है 20 हफ्ते पे? थोड़ा सा क्या मतलब है? मतलब एम ही मारी जा रही है.
नहीं सर, इनको जो है ना, we will shift her to the OT because in 3 weeks there has not been any significant improvement.
वो तो पहले उसको काउंसलिंग में बताओगे शिफ्ट करने से पहले. What is your plan of management? वो तुम लफ्ज बोलने से कतरा रही हो. तुम कह रहे हो कि टर्मिनेशन करोगी प्रेगनेंसी, तो बोलो टर्मिनेशन अगर बोलना है तो. काउंसलिंग उसके मुताबिक करो. वो टर्मिनेशन नहीं कर रही, थिएटर में ले जा रही है.
मैं एक बात छोटी सी पर्सपेक्टिव, नहीं ठीक है, एक पर्सपेक्टिव में चीज डालने के लिए सना you must highlight the fact that she has got previously no live issue. नहीं,
she has 2 live issues, 2 boys.
Ma'am, she has 2 boys and 1 IUD.
ये देखें जी, ये यहाँ पे एक फर्स्ट में मेल अलाइव एंड वेल, सेकंड में फीमेल IUD, थर्ड में.
I'm sorry.
मैडम आपने तो इसको ट्यूब लाइगेशन एडवाइस की थी.
So और दूसरा, I would also, because her blood group is A negative, I would also give her
It's A negative?
Yeah, it's A negative. And she has had a significant hemorrhage, so I would also give her anti-D. After inquiring the blood group of the husband.
How will you quantify how much
Fly-hour
anti-D
test.
should be given?
Through a fly-hour test. But initially, because she's at 20 weeks, so she should be given 500 international units of anti-D stat. And then after doing the thyroid test, if there is the fetal maternal hemorrhage is more than 4 ml of RBCs, then she should be given additional dose of anti-D depending on.
But she's been bleeding for 3 weeks.
500 तो देंगे start में, फिर उसके बाद.
ये जो प्लेसेंटा से ब्लड आता है, ये मैटरनल होता है कि फीटल होता है? ये ब्लड जो है, do you think that it is the fetus who's bleeding or it is the maternal bleeding?
Maternal.
Sir, maternal.
fetus तो इतना bleed कर जाता तो अब तक फौत हो गया होता. अच्छा चलो, मैं मतलब इसमें चीजें बताने वाली और है. नेक्स्ट, इनका अल्ट्रासाउंड हुआ 1 अप्रैल को. 1 अप्रैल को अल्ट्रासाउंड में अगर आप देखो तो यहाँ पे large subchorionic hemorrhage noted along the whole length of left lateral wall having internal septation. Debris is also noted within the amniotic fluid, suggestive of intra-amniotic hemorrhage. This is an ultrasound done by someone whom we rely upon. Why do you want to do Doppler? What for? Good. पूछे सवाल जरा. Doppler क्यों करना चाहते हैं आप? किस चीज का डॉपलर करना चाहते हैं?
फीटल एनीमिया चेक करने के लिए.
फीटल एनीमिया चेक करने के लिए. कहाँ का डॉपलर करेंगे आप?
MCA
Middle cerebral artery Doppler.
MCA Doppler.
Relevant at 21 weeks.
No.
यूट्राइन आर्टरी डॉपलर तो इस वक्त करते ही नहीं है वैसे. I am not a fetal medicine man, but uterine artery Doppler in second trimester is not really relevant. करता ही नहीं है अगर आप पूछो तो. अल्ट्रासाउंड वाले काफी सारे करते हैं, लेकिन फीटल मेडिसिन वाले ने स्पेसिफिकली मुझे बताया था कि ये हम इस वक्त नहीं करते. No, there is no morbidly adherent placenta. That has not been reported, and the ultrasonologist who has done this would have reported that. अब ये है 1 अप्रैल का, जरा गौर करो. अब यहाँ पे आ जाता है, यह है 4 अप्रैल का अल्ट्रासाउंड. 4 अप्रैल के अल्ट्रासाउंड में अब एक चीज मैं दिखाऊंगा. अगर आप देखो, वो वापस जाओ उधर, 47 मिलीमीटर है सर्वाइकल लेंथ, और इधर आ जाओ तो यहाँ पे आ गई 25 मिलीमीटर 4 अप्रैल को, और साथ में जो ब्लड क्लॉट है वो बड़ा हो गया, उस सिग्निफिकेंटली बढ़ गई है उसकी जो अमाउंट है. अब बताइए क्या करेंगे? जल्दी से कोई लिख दे कि क्या करेंगे? टर्मिनेशन करेंगे. अब जब टर्मिनेशन करनी है तो आपने अच्छे पॉइंट्स बोले थे काउंसलिंग के, जरा आहिस्ता बोलोगे, लेकिन वो काउंसलिंग के पॉइंट्स आप जरा दोबारा से बोलिए.
I would counsel the mother and the
Family
I
and
would
the
counsel
husband.
the family and the husband that this pregnancy is a high-risk pregnancy,
Mm.
which has risks associated, maternal and fetal risks. Risks to the mother include risk of anemia, prolonged hospitalization, blood transfusions, and associated complications with that, along with operative delivery. And there are, along with that, there are also risks to the fetus, which include risks of fetal hypoxia.
और बच्चा तुम टीओपी करने जा रहे हो,
हाँ,
फीटल रिस्क को बस करो.
IUD. इतना ही है.
ये लिखो, counseling about bleeding getting worse, need for termination of pregnancy, get to the point. In view of previous 3 cesarean sections, surgery होगी, hysterectomy होगी. No attempt at vaginal delivery. Need of cross-matched blood. Blood group है A negative. 4 मत बोला करो, उनको होगे कि adequate amount of. ये देखिए, ये blood transfusion के बारे में मैं जरा कर दूं आपको. You see, even in part 2 examination, the candidates, when they say that I will get an X-ray done because of anesthesia, etc., that is the domain of anesthetist. Let anesthetists do those investigations which they deem appropriate for a surgery. Similarly, it is unfortunate that we do not have good blood transfusion services available in our country. That's why we have developed this habit of saying that I will cross-match 4 pints of blood. Essentially, that is not the surgeon's domain to do that. That is the domain of the blood transfusion department. So what we'll do is that we will communicate to the blood transfusion department that we will need large numbers of cross-matched blood for this patient, 4, 5, 6, or 10. since those services are not that well developed and are not available, that's why we get into this habit, the residents get into this habit of arranging cross-matched blood on their own. This I am explaining,
and the examiners as well.
and the examiners also. So therefore आप ये कह दो examination में, लेकिन आप अपना vision जो है उसको जरा broad रखो. You are going to be specialists, and maybe some of you, हमने नहीं किया, लेकिन आप में से किसी को वो हो कि वो ब्लड ट्रांसफ्यूजन डिपार्टमेंट की डेवलपमेंट में इतना काम करे, तो वो उस तरीके से आप बोलो. और यहाँ पे पॉसिबल नीड फॉर रिमूवल ऑफ यूट्रस की जरूरत पे कर देना चाहिए कि अनफोर्सीन अगर हो जाए. मेरे ख्याल में ये 5 पॉइंट बनते थे काउंसलिंग में जो बोलने थे. यहाँ पे किसी ने अप्रोप्रिएटली लिखा था कि सिंपैथेटिक होना चाहिए. वो प्रोबेबली इसलिए कि जिस तरह से मेरी टोन हो रही है कैंडिडेट्स के साथ, उसको मद्देनजर रखते हुए उन्होंने कहा जी जरा मरीज के साथ हाथ हौला रखें.
What about ligation? What about RH sensitization?
हाँ जी. अब
What about the blood group of the husband?
I mentioned that we will also inquire about the blood group of the husband, and if that is positive, we would give anti-D 500.
अब जब वो करना है तो उसमें मैनेजमेंट में प्लानिंग एंड प्रेपरेशन, ट्यूबल लाइगेशन डिस्कशन, ये और फिर ले लेना तुम बाद में उसकी तस्वीर में बताना लगा. हिस्टेरोटमी का इंसिजन कैसा करना है, आपने ट्रांसवर्स करोगे, वर्टिकल करोगे, और बेबी की रेसिसिटेशन करोगे कि नहीं करोगे, और फिर पोस्ट ऑपरेटिव केयर क्या करोगे. इसमें हम ऐड कर सकते हैं, जो मैं अभी ऐड कर देता हूँ, कि इसमें हमें यहाँ पे वो एंटी-डी के बारे में भी बात कर लेनी चाहिए. एंटी-डी.
So how much time does it take for the antibodies to develop when RH sensitization takes place? Would it be that the antibodies would already be present?
It might be.
So the questions हैं एंटिटी के बारे में. अभी लोअर सेगमेंट नॉट फॉर्म्ड, आपने कहा वर्टिकल इंसिजन दिया जा सकता है. मैंने किया था, मैंने तो ट्रांसवर्स से ही किया था, उसी में से निकाल लिया था. एक बात है. ट्यूबल लाइगेशन, डॉक्टर रुबीना ने पेशेंट टेबल पे लेटी हुई थी, तो इन्होंने आके उसको कहा कि तुम्हारे 3 सिजेरियन सेक्शन हो गए हैं, तो तुम ट्यूबल लाइगेशन करवा लो. तो पेशेंट ने कहा जी मेरी ट्यूबल लाइगेशन कर दें, और उसने कहा कि जरूर कर दें, मैं नहीं और ऑपरेशन कराना चाहता. मैंने नहीं की, बिकॉज मैंने इसलिए नहीं. डॉक्टर रुबीना की जो वो एडवाइस थी वो बिल्कुल सही थी, वो एडवाइस डिस्कशन होनी चाहिए. बट आई थॉट ऑपरेटिंग टेबल वाज नॉट द राइट environment or right time for making that decision, because the patient in that situation, आपने देखा नहीं है, लेबर में आती हैं खवातीन और आगे कहती हैं कि बस आइंदा मैंने बच्चा पैदा नहीं करना. वो पहले बच्चे के साथ ही ऐसा करती. So under those trying circumstances, one may not have an objective thinking, and therefore in light of that I did not do her ligation. ठीक है जी. और ये निकला था उसका प्लेसेंटा. इसमें इतनी तस्वीर साफ नहीं आ रही, लेकिन अगर आप देखें ये इतना सा, इट्स अ लार्ज ब्लड क्लॉट. ये जितना आपको साइड टू साइड नजर आ रहा है, इतना ही ये फ्रॉम फ्रंट टू बैकवर्ड भी था. इसके साथ काफी सारा नेक्रोटिक मटेरियल सा भी था जो कि मेम्ब्रेन्स का हिस्सा था. द फंक्शनिंग प्लेसेंटा वाज ओनली अबाउट दिस मच एंड द रेस्ट हैड सेपरेटेड, और ये उस तरह से है. दिस वाज द फीटस. तीसरा जो केस है ना, वो है जरा इम्पोर्टेंट. वो उसकी बाद में कर लेना. डीएनआर की वो बाद में कहूँगा. 20 वीक्स पे कोई नहीं करता डीएनआर, कुछ नहीं होता. उसने गैस किया. पेशेंट इज 43 years old. ये देखो, शी इज अ डॉक्टर and para 2 both normal deliveries. Last child was born 18 years ago. Menstrual cycle previously was regular, normal, average loss. For 2 years she has a shorter cycle and heavy loss with clots. Now for some time she has history of postcoital bleeding. Already she had a PEPL on she presented on 10th of February to me, and on 24th of January she already had a PEPL which showed secretory endometrium, and on 8th of February she had a pap smear, and this is the report of the pap smear. Pap smear में वो बाद में मैं बताऊंगा आपको कि क्या है. there was this scattered squamous neoplastic cells were reported in that pap smear. Although यहाँ पे वो कह रहे हैं कि inadequate for cytological evaluation, cervical smear की diagnosis ये है. ये सबकोरियोनिक हेमाटोमा क्यों डेवलप हो उसकी बात बाद में कर लेंगे हम किस तरह से. सो ये वाला है inadequate for cytological evaluation. अब दोबारा से उसी पे आ जाते हैं. पैप स्मीयर हुआ तो उस रिपोर्ट को देखते हुए उन्होंने कहा हाउ विल यू काउंसल हर, व्हाट वुड बी हर लाइन ऑफ मैनेजमेंट. शी बीइंग डॉक्टर having postcoital bleeding and having a pap smear which shows some neoplastic cells. वो आई है तो क्या करेंगे आप? क्या करेंगे? हाँ
जी सर.
कोल्पोस्कोपी
सर
करेंगे.
इसकी कोल्पोस्कोपी
सर वो सर
कोल्पोस्कोपी गाइडेड बायोप्सी.
ठीक है. हमने क्या किया उनका काउंसल, तो एक तो वो तसल्ली देने वाली बात है. सो इसमें आ गया काउंसलिंग. हमने कहा कि रिपीट स्मेयर भी करके देख लेते हैं. रिपीट स्मेयर हमने लिक्विड बेस्ड थिन प्रेपरेशन, लिक्विड बेस्ड साइटोलॉजी की, और उसमें एडिक्वेसी ऑफ द स्मेयर वाज सेटिस्फैक्टरी, और few benign squamous epithelial cells and inflammatory cells, and the diagnosis now came negative for intraepithelial malignancy. अब डॉक्टर रुबीना बताएंगी ये जो लिक्विड बेस्ड साइटोलॉजी.
मैं तो ये बताना चाहती हूँ कि लिक्विड बेस्ड साइटोलॉजी के साथ डीएनए टेस्टिंग भी करवाई फॉर एचपीवी, क्योंकि इसके साथ अगर आप एचपीवी की टेस्टिंग करा लें and that turns out to be negative as well, then the woman is secure for 5 years. And
Right.
it should be done, if the patient is reporting, it should be done as a part of the liquid based cytology.
In this particular patient, we didn't do that because there was that fear of that thing. वो जैसे कॉल्पोस्कोपी की बात उन्होंने की है कि वो न्यूप्लास्टिक सेल्स नजर आए थे, तो हमने ये रिपीट करके लिक्विड बेस्ड साइटोलॉजी प्लान ये किया कि हम रिपीट स्मीयर के बाद कॉल्पोस्कोपी और लेट्स करेंगे. और फिर हमने ये किया, और कॉल्पोस्कोपी पे अच्छा इसमें ये वाली चीजें 2-3 मैं आप, एक तो सर्वाइकल ब्लॉक दिया था, जनरल एनेस्थीसिया नहीं दिया था. दूसरी चीज ये किया था कि हमने एसिटिक एसिड लगा के भी देखा था. तो मैं इसमें बात करना चाहूंगा VIA वाया जिसको बोलते हैं, विजुअल इंस्पेक्शन आफ्टर एसिटिक एसिड, के लो रिसोर्स सेटिंग्स में व्हाट इज द वैल्यू ऑफ वाया. ये आप अपने जहन में रखिए और इसको ढूंढिए कि क्या करना है.
Actually, it is a very good screen. VIA is a very good screening test for low resource countries because it is easy to do. It is cost effective and it can be done even at the level of the simpler facilities like in the rural health centers.
DHUs and
the only training that is needed is to compare. या आपके पास अगर atlas हो, you just need to compare कि ये picture जो है वो कैसी आ रही है. But it is as simple as that. That if there is an acetowhite area, it needs to be evaluated. So it must be done every 3 yearly in all women that you are seeing. If you can't do a pap smear.
And I also want your attention to be drawn to this area कि ये patient's identity जो है वो obscure की गई है. So on examination, cervix looked hyperemic. It bled to touch. Acetowhite area on posterior lip of cervix was seen on application of acetic acid. No abnormal vascularization was noted. Iodine was applied और उसके बाद फिर ये जो large loop excision of transformation zone was performed, area cauterized ये operative notes and transformation zone के, और specimen anterior lip for biopsy and posterior lip for biopsy. ये था. और वाया का देख लेना. ये है final histopathology की report, specimen 1 and 2. Specimen 1 section shows ecto and endocervical mucosa, which means that it was adequate with mild mixed inflammation, and ecto and दूसरा specimen mucosa with mild inflammation, no evidence of dysplasia or malignancy, and the patient went home happily thereafter. So with क्योंकि ये डेफिनेटिव डायग्नोसिस वाली बात इस तरह से हो जाती है।
अब अगर आपको एग्जाम में सिचुएशन हो तो इसमें डिबेटेबल पॉइंट हो सकता है दैट इफ द thin smear was normal, did you really need a colposcopy? But the patient was a doctor and she was not satisfied, and
And
she
because of the
wanted a
presence of those
confirmatory-
neoplastic cells,
because of the presence of neoplastic cells, she was anxious and she wanted
जो
a confirmed diagnosis.
now this is the first smear report. इसमें जो important points मैं highlight करना चाह रहा था वो ये था कि sir unsatisfactory, predominantly blood obscuring cells, which means when there is bleeding, smear should not be taken because those blood cells obscure the cervical squamous. वो उनको obscure कर देते हैं. So assessment of the squamous epithelium, which is the objective of cervical smear, that cannot be adequately done. And that's why the adequacy of the smear was unsatisfactory. But still, smear reveals predominantly blood, rare benign squamous cells, scattered squamous neoplastic cells. Now, this was something which actually necessitated all that followed this, and rare endocervical cells. Presence of endocervical cells again also would have shown adequacy of the specimen, because whenever a specimen is taken, even if it is not smeared with the blood cells, that shows the adequacy of that. And that's why the inference here was inadequate for cytological evaluation. So there was no opinion actually given, but it was only, and anyway, even if this was not there, the smear needed to be repeated. So the take-home points from this are, number one, that the questions that I would want you to look at, what are various methods of cervical screening? And please remember what Professor Rubina said about liquid-based cytology. Number one, preferably that should be done. Number two, combining it with
HPV screening,
HPV screening.
DNA.
वो और साथ में हमने बात की है visual inspection of the cervix after acetic acid VIA वाली, वो because वो उसमें aceto white areas हो जाते हैं. Those are the areas जैसे पहले Schiller test होता था. आप जाइए जाके देखिए कि Schiller test क्या होता है, और फिर आप ये भी देखिए कि acetic acid वाला क्या test होता है. So Schiller test, acetic acid test, these acetic acid test तो ये लेस डेवलप्ड कंट्रीज में आ गए, और फिर स्मेयर वाला बात जो है वो, और उसके बाद स्मेयर के साथ अब HPV DNA वाली बात आ गई है, उसके बाद फिर कॉल्पोस्कोपिक असेसमेंट आ गई है. सो दैट इज द स्पेक्ट्रम ऑफ सर्वाइकल असेसमेंट. इसको आप उस तरह से, ये मुख्तलिफ सवाल हैं, इनके बारे में आप जानिए ताकि इनको आप फिर एक कोहेसिव आंसर आपका बने या आपका कॉन्सेप्ट बने, एंड देयरफॉर दैट यू कैन अप्लाई देयर. थैंक यू वेरी मच. मेरा ख्याल है कि ये
सर बट काउंसलिंग कैसे करेंगे इस पेशेंट की? मैं थोड़ा सा ट्राई करूं काउंसलिंग
के लिए ये वाली स्लाइड जो है ये काफी इंपॉर्टेंट है. That all right, there were those cells which are so called neoplastic cells, but the pathologist or the cytopathologist did not take them seriously, and his comment or their comment was that it was inadequate evaluation. A proper evaluation could not have been done. Now, even if there were cells of, say, undetermined significance as ascus or eggcus, those cells, whether they are glandular cells or squamous cells, when sometimes the report comes of screening that there are cells which are of undetermined significance. What do you do in those cases? Then you repeat smear. Then, and if you have facility, you also do DNA of HPV diagnosis, and if still there is doubt and there is no confirmatory direction, then what you do? Then you go for if facility is available, for colposcopy and colposcopic directed biopsy. And if colposcopy is not available, you still can go for LETS, because LETS is something which will, LETS or cone biopsy, as previously, LETS is comparatively better than that because it does not involve going up to the internal os level, because when you are removing a cone, then you remove that junctional area or transformation zone, making the base of that, and the apex of the cone is at the top. And and instead of doing that, you just do that. Let's कर लेते हो. So
Sir,
let's
I want to ask.
हाँ जी.
Sir, देखिए अगर ascus, if the ascus comes on the pap smear and they say atypical cells of we have to take it as a borderline or low grade squamous, in which there's a risk of CIN1. I just want to clear that. How would we level the atypical cells? How would we take it as a borderline or a low grade or a
No,
high
I
grade?
wouldn't, because the name implies, that acronym implies cells of undetermined significance. Now, if there is undetermined significance, the cytopathologist doesn't want to weigh their opinion this way or that way. And therefore, that is a situation which needs to be monitored, which needs to be reassessed, so that you reach a conclusion that there is no chance or no possibility of malignancy, or there is a possibility of malignancy. And if there is, the best method to rule that out and to give a final verdict is to assess histologically the transformation zone. And to get that, you have two options: cone biopsy or LETs. We do not generally do LETs because that needs a small, insignificant kind of, instrument or implement, which if we start doing that, we can have, and it was eminently done under local anesthesia. I regret that I didn't do that. Dr. Talha did the colposcopy, and he did that LETs procedure. We should have made some pictures of that. The next time it is there, we will make that. But that just settles the issue. Now, in this particular case, since you said that how would we counsel the patient? Because this has been done, and that area which is of potential trouble, that has been removed, and it has been shown clearly that there is no evidence of dysplasia or malignancy. जी, ये लुगोल्स आयोडीन साफिया आपने कहा कि ठीक है, रिच एपिथेलियम हेल्दी इफ नॉट टेकन, तो वो कलर नहीं होगा. ये शिलर्स टेस्ट होता था, और वो जो एसिटिक एसिड है वो भी इसी तरह से है. काउंसिल के स्पेलिंग जरा ठीक करो रानिया, फॉर बीइंग हाई रिस्क सेंसिटिव हिस्ट्री टेकिंग. यस, हाँ वो ठीक है. और आरवी डीएनटी हैव साइटोलॉजी इन पेरिफेरी फैसिलिटी. ये सारी फैसिलिटीज नहीं है, लेकिन वही तभी उन्होंने कहा जो पेरिफेरी में है, अगर वो नहीं है, आप अगर ऐसी सिचुएशन है तो एसिटिक एसिड जो है, दैट्स very
वैसे this country needs a robust program for cervical screening, because सारे South Asian countries में
हमारा
programs available हैं, and we are lacking, and
और हमारा incidence हाई है,
and we have a high incidence of CS cervix, and you are going to be the future of this country. You must remember to do cervical screening for every woman who is coming to you.
ये आज से 20 साल पहले वो प्रोफेसर लतीफा शमसुद्दीन जो हैं, उन्होंने मुझे खास तौर पे, मैं बांग्लादेश गया, उन्होंने जाके मुझे दिखाया, उन्होंने पूरा प्रोग्राम बनाया हुआ था, वाया का विजुअल इंस्पेक्शन ऑफ एसिटिक एसिड के साथ उन्होंने अपनी जनरल पॉपुलेशन में किया. आप अपने तौर पे वेयर एवर यू आर, प्लीज डू सच थिंग्स. ये आप इवन बिफोर योर एग्जामिनेशन, इवन इफ यू आर इन ट्रेनिंग, आप ले लो. आपको कि जी हमने ये सर्विक्स का असेसमेंट करनी है, हमने ओपीडी में सबका सर्वाइकल स्मीयर लेना है, हमने एसिटिक एसिड लगा के देखना, वगैरह वगैरह, जो ऐसी चीजें हैं विच आर जनरली कॉस्ट इफेक्टिव, सजेस्ट करें अपने यूनिट्स में एंड इम्प्लीमेंट देम. और उसी से फिर जो है वो द ऑब्जेक्टिव ऑफ दिस एक्सरसाइज ऑफ आवर 1 hour here is to discuss cases. As we go on, we are for the passing of the examination is only one objective. That's in my opinion, comparatively minor objective. The major objective is to share various areas associated with knowledge, application of that knowledge, and improvement of women's health in our country, in our periphery particularly, and the knowledge and application of the the new generation of gynecologists. हाँ, आपने एक सवाल था कि वो हेमेटोमा कैसे बना उसके. हेमेटोमा, you see, ये इसी तरह से जिस तरह से पूछा कि जी ये threatened abortion क्यों हुई. Now, threatened abortion, you see, is मैं उसकी तरफ आता हूँ, hematoma कैसे बना. There, in 40% of pregnancies, according to one estimate, there is bleeding in first trimester. Now, why does that bleeding happen? Because the placental bed, which is not restricted only to say about small area, comparatively small area of the uterine surface, which it is at term, at the time of conception and in early pregnancy, a major part of the uterine surface is covered with what is going to be placenta. And it is only with enlargement of the uterus that placenta is restricted to one area, number one. Number two, placental bed is so rich in blood supply. You see, in a term pregnancy or near term, there is 700 milliliters of blood which is circulating at any given time in the uterus. So it is very rich in blood supply. It's a very vascular area, and the blood vessels are dilated. You know that. And it is a wonder that they do not rupture or they do not bleed so often as they ought to, and it is only restricted to a comparatively smaller percentage. So 40% of the pregnancy would have a small or large bleed, and many of them, they continue unabated and without any significance. But if there is that small amount of that there is a punctured blood vessel, it will bleed, and that bleed can become larger and larger. It can expand, it can cause shearing of the placenta from the uterine surface, and that results in that hematoma formation. Now, depending upon the site of the hematoma, it may extend and it may be contained. So if the blood vessel gets उसको क्या हो गया, थ्रम्बोज हो गया या क्या होता है, हाँ, वो थ्रम्बस बन जाता है. If it shuts down, then the formation of the clot will be restricted. Otherwise, it will continue to grow और हो जाता है. हमारा टाइम हो गया. Right? Okay जी, thank you very much.
Thank you, sir. Jazakallah.
Thank you, sir. Jazakallah. Thank you. Thank you, ma'am.
अच्छे
Thank
cases
you.
हैं.
Good cases today.
Huh?
I think
Thank you,
there's-
sir. Allah Hafiz.
But yeah, आप लोग सारे इस पे गौर करें. 3 cases बड़े important थे. All topics are very relevant for the exam.
सर
Thanks a lot, ma'am and sir. Thank you.
जिसके अंदर से हम ये सेन और एसएस वाला अपना कंसेप्ट बिल्कुल क्लियर कर सके. एक क्योंकि ईबीएम भी अब उसमें एक तो गाइडलाइंस नहीं आ गई हैं, तो एक काइंडली एक बुक सजेस्ट कर दें जिसमें से बिल्कुल क्लियर हो जाए कंसेप्ट.
किस चीज का?
मैम ये सिन का जो भी पता है, सेन और हमने डिस्कस किया है, ये एसएस और रिगार्डिंग
Discuss.
साइकोलॉजी.
चलिए इसके बारे में एक प्रेजेंटेशन बना लेंगे, करेंगे, ठीक है.
Okay.
स्क्रीनिंग के बारे में, सर्वाइकल स्क्रीनिंग की एक प्रेजेंटेशन कर लेंगे, ठीक है.
गाइडलाइंस भी न्यू आ गई हैं 2020 में, और ईबीएम में थोड़ा सा
तो हर
change
साल ही आ जाती हैं गाइडलाइंस.
अस्सलाम वालेकुम मैम रुबीना
अस्सलाम वालेकुम सर.
Assalamu alaikum.
आपका ये म्यूट हुआ